to the Home of Medicine podcast, a podcast in association with the European Federation of Internal Medicine. My name is Dr. Amie Burbridge. I'm a consultant in acute and general medicine in the West Midlands, and today I'm joined by the ever brilliant...
Hi, my name is Dr. Ben Lovell. I'm also a consultant in acute and general medicine working in central London.
Thank you so much for joining me again today, Ben. A massive shout out to all of our fans, because I'm so proud that last month we managed to be, I think it was number 3 in the UK medical podcast. So Ben, a massive thank you to you for helping us achieve that. So my aim is to get to number 1. Okay, Ben, so
Me too. I like it when they give us the tweets and things saying they like it. I love it when they send us an email.
I know, it's so nice. So if anybody wants to send an email to us, and we always reply to them as well.
Yes, we do.
Fab. Okay, so Ben, you've got a case for me today.
Are you ready?
Always.
This is a case, it's quite an oldie now. It's when I was a registrar. Hang on, I've just aged myself quite horribly there. It's not that old.
A few months.
It's from 2017. So I was a final year registrar, and I was working in ambulatory care, and I was working alone because it was a weekend, which was the staffing of our ambulatory care at weekends. The ambulatory care registrar was there solo seeing patients, and I saw a 76-year-old female who was sent in by the GP, and the GP had actually referred her yesterday, being Friday, but the patient was busy and decided to come in on the Saturday when it was a bit more convenient for them because they had things on the Friday, which is always interesting because ambulatory care falls under the umbrella of same-day emergency care, and popping in the next day usually implies they don't feel too bad, they don't feel so unwell.
Yeah.
Maybe it's not a same-day emergency, but sometimes patients aren't quite concordant with the assessments of their doctor. So she came in, this lovely 76-year-old lady, and the referral from the GP was thus. This lady woke up with severe back pain in her right posterior ribs. She had her varicose veins operated on 2 weeks ago, and apparently she's had some hemoptysis. So I'm worried she might have a massive PE. Please, can you see? And that was the information that I had. So the fact the patient felt it was all right enough to wait 24 hours and come in the next day was the first influence on my sort of clinical reasoning. But I met the patient, and she was a very fit, independent 76-year-old lady. She's 2 weeks post having a varicose vein stripped, very routine surgery, which went off nice and straightforward. And she said that she woke up, and she said it was 2 days ago now. So when she saw the GP yesterday, the back pain was the day before, was yesterday to then. So she woke up with severe thoracic posterior right-sided pain 2 days prior to my meeting her, which is now completely resolved, and she is symptom-free. And she's never been breathless at all throughout any of this, and she's never had this before. And I said to her, but it says here your GP said they thought you were coughing up blood. And she went, well, actually, I just had eaten a whole bowl of prunes, and I think I just coughed up a bit of prune-stained phlegm. And I don't think it was blood, but I wasn't sure. So that was my assessment. And I quickly established she was the fittest 76-year-old I've ever met. She's never smoked or drunk alcohol. She took no medications except for some calcium supplements, which she took to ward off osteoporosis. And apart from this varicose vein business a couple of weeks ago, she was fit as a fiddle. She still looks after her grandchild 5 days a week to help out with childcare arrangements. So that was the history. I'll pause a second here. Do you have any bright ideas or questions about the history as presented?
So 76-year-old female, very fit and well, no significant past medical history at all. You did say that she was on calcium supplementation to ward off osteoporosis.
Yes.
So is that because she's been told she's osteopenic, or is that because, that's just what she feels that's the right thing to do?
It was supplements which she bought under her own steam from the health shop, but she has never had a bone scan or have been told she has any problems with bone density at all. So this was a supplement she was choosing to take.
Okay, and no previous fractures at all that she'd
None.
had? Okay. So she'd also had varicose vein surgery as well. You mentioned 2 weeks prior to that. When she'd had the varicose vein surgery, was it a day case or was she admitted into hospital?
I've got a feeling she was admitted overnight and discharged the next day with her legs in dressings.
Okay. And it'd be interesting to know how immobile she was after the surgery. Was she given prophylactic? Okay. Prophylactic enoxaparin.
No, she wasn't actually. No, no.
Mhm.
She's well enough to walk out of the hospital and make her own way home the day after
Oh,
surgery.
wow.
And she has
Okay.
not been given prophylactic low molecular weight heparin during the whole event. No.
Okay. So her main presenting complaint was severe back pain, thoracic back pain. Was this associated with any neurological symptoms?
It was not at all.
Okay.
Interestingly, when I made my assessment, the back pain had gone. And so she sort of showed me where it was. You know how you can't touch your own thoracic
Mm.
spine. So I turned around, she showed me on my back, and it was right to the right of her thoracic spine, not on the spine. So it was right posterior ribs. And it was sort of in like 2 or 3 rib spaces. She said it was really, really painful there,
Mm.
really, really hurting, but it's all settled down and gone now.
Had she had an injury?
None.
Because that's a very specific location, isn't it?
Mm.
I'm just now trying to feel my right posterior thoracic. Can't do it. Okay, so there's been no injury. And he said there was no shortness of breath, no cough. Had she had any problems with the bowels or a bladder?
Neither of the above.
Okay. How long did the pain last for in total?
It lasted for the whole day, which is what triggered her to call her GP and make an appointment for the day
Okay.
after, the next day.
But it had then gone by the time.
Yes. Yeah. So it probably
Okay.
lasted just under 24 hours altogether.
Okay. Did the pain radiate anywhere else, into the arms, into the neck?
No, it didn't. It was just in that one area. And I got her to do a few motions, you know, hold the opposite shoulder and twist your thoracic spine to the left, to the right, forwards, backwards. Couldn't reproduce it. I got my knuckles in her rib space and said, is that tender? Is that tender? But there was no sort of muscle soreness there that I could reproduce.
Any fever?
No.
Any weight loss?
No.
So I'm thinking of like constitutional symptoms,
Yeah.
back pain, is this discitis? Unlikely, it's
Usually my discitis is agonizing at minimal movement, so they can't tolerate any movement of the spine, any degree in any direction. So it'd be strange for it to come and gone.
Yeah, absolutely. The other thing that's going through my head is thoracic back pain, calcium supplementation. Has she had an osteoporotic wedge fracture?
Yeah, that was an interesting one, because I've seen people before I've seen a lot of people with these sort of wedge fractures ranging between absolute agony and bedbound and having to wear a brace for 6 weeks, to people who just sort of keep going around their normal life, and it sort of gets picked up incidentally on an x-ray or on a scan or a chest x-ray for something else. So I've seen such a large spectrum of presentations, but I thought that was a good idea. Strange it was more on the meat and bones of the posterior rib cage rather than over the spine itself, though.
Okay. When you assessed her, and I guess you did your end of the bedogram, did she look well or did she look unwell?
She looked healthier than me. She was hobbling a little bit because her legs were still dressed following her surgery. They still had these dressings in place, but she walked in nice and sprightly. She sat up, sat down, and the endobedogram was a very robust, sprightly looking 76-year-old who was not obviously breathless or in pain or pale or sweaty or clammy or clutching anything in pain or vomiting or grimacing or any of those sort of overt or covert clues that we pick up on for when another human being is sort of out of balance a little bit.
Okay, so going back to observations then, what were they like?
Sure. So her heart rate was 76, her blood pressure was 134/79, respiratory rate was 18, and her saturations were 98% on room air.
Okay, so pretty much perfect.
Yeah.
And she was apyrexial as well?
Apyrexial, yeah.
Okay, so clinical examination then, did you find anything?
So I examined her chest. It was completely clear. Her thoracic spine exam, as I say, was fine. Looking at her legs, they were dressed in the dressings post-operatively, and I guess they were a little bit swollen, as you would expect to be after having some veins removed from your legs. But there was a very slight asymmetry. I think the right leg might have been 1 centimeter in circumference bigger than the left one, but they were uniformly a little swollen. So my examination really didn't pick up anything at all apart from those legs.
Okay, so I guess what's going through my head is recent surgery, varicose vein surgery. Although her observations are okay, she's had some pain, although it was in the back. Could she have a PE?
Yeah, and the GP questioned it, We talked in a previous podcast about how difficult it is to change lanes when you've been served a patient with a potential diagnosis, and how it's quite tricky sometimes to either change to a different lane and say, I think this is a different diagnosis, or reverse down that lane and say, no, 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 this is nothing. The patient does not need any more tests and they can go home, they are fine. I find that tricky to do, especially at the stage I saw the patient, which when I was a registrar, more junior than I am now, albeit at my final year. But having the GP send in saying, could it be a PE? I didn't think it was. No, not really. I guess it could be. And I guess now when I talk about things with patients and with other doctors, I don't tend to use the language of this isn't this. I tend to use the language of anything is possible, but the risk is so low, I'm satisfied that we can stop at this point. And I do that a lot, for example, in my thunderclap headaches referrals. So when I get a thunderclap headache, refer to medics for a lumbar puncture, and I see the patient, and you can never say never, but I do often find myself saying to the patient, anything is possible. However, the risk of you having had a bleed in your brain is such a low risk. It's there, but it's such a low risk. It's actually, to me, lower than any risk of a lumbar puncture. And therefore, that's why I'm swinging towards, we don't do a lumbar puncture here. Does that make sense to you? And the patient will say yes or no. So I never say this is never going to be this, because the things we've seen over the years, anything can be anything. But I tend to talk about in terms of risk now. And to me, the risk was so low rather, I would have been happy at that point to stop and say, I don't think we need to go any further with this. What do you think?
Yeah, it's interesting because, when I look at, I think about this lady's problems. So whenever I'm really stuck with a patient, could be clinically, any reason really, I go, okay, so what are the patient's problems? Okay, so she's 76, recent varicose vein surgery, severe back pain on the right, but she's got normal observations, normal examination apart from the varicose veins. If you do a D-dimer, it's going to be elevated anyway because she's just had varicose vein surgery. There's going to have been some fibrinogen degradation products being produced just primarily from having that surgery. So actually the D-dimer is probably not going to be useful anyway. And it's D-dimers are up there with LPs for subarachnoid hemorrhages in my list of things that I dislike. I think I could do a whole podcast on the lumbar punctures and subarachnoid hemorrhages. But so it's hard, isn't it? Because the GP's given a diagnosis, and I guess you could say she could have a PE, although severe back pain on the right that's now gone, that isn't the presentation of a PE.
It absolutely isn't. And we've talked about this again before, about getting patients getting assessments at the front door before a doctor's seen them. And this happened in this case, and I was handed the blood results, and her FBC was normal and her U's were normal. Her CRP was 79 and her D-dimer was done, unfortunately. Our cutoff is 550. Hers was 1,860. So it's just over 3 times the upper limit of normal. Now, I went down the exact same mind line as you. She's 2 weeks post-op. Of course, she's got fibrin degradation products in her system. And then your other voice, you've got an angel and a demon on one shoulder and the other shoulder, devil on the other shoulder goes, but is 1,800 what you'd normally expect 2 weeks post-op? I don't know. A CRP of 79. Well, she's in an inflammatory state. She's 2 weeks post-op. But is 79 2 weeks, is that higher than you would expect for someone to have a post-operative CRP response? I don't know. My gut at the time thought, gosh, that CRP is a bit high for someone who's 2 weeks down the line. But in the absence of a focus of inflammation or infection, what to do?
I mean, just another thought is she's had recent surgery. Could this be a chest infection? Could she have, I can't imagine she was, lying down for very long periods of time or, caught an infection in the hospital. But I'd want to do a chest x-ray to see if there was anything on the x-ray to look for infection. And also, has she fractured a rib that she doesn't know about? Is there an osteoporotic wedge fracture there? So I think that might help to rule out some of the conditions that she may have. The D-dimer, is that a red herring? I don't think we can really look at that D-dimer in the context of this situation. It's non-interpretable because she's just had major varicose vein surgery.
Yeah, I completely agree now. This case to me as presented, that I say those exact same thing as you, that D-dimer is uninterpretable. And everyone knows an isolated D-dimer on its own diagnoses nothing. It diagnoses nothing at all. You have to have suspicion for VTE first to give the D-dimer any meaning. So at the time, I was trying to help my decision making by using evidence, by using validated tools. And I was thinking about the Wells score. But of course, you only apply the Wells score if you're already suspicious that they have a VTE. If you applied the Wells score to every single person walking down the high street, they'd all have different scores on the Wells score. And it doesn't mean anything because you're not thinking about VTE. And I always did struggle with Wells score because it's got that one question in, which gives you 3 whole points. So is an alternative diagnosis more likely in the PE? And that all, if you give them that or you don't, that throws 3 points into the mix.
Yeah.
You put them completely into high risk or low risk, depending on what mood you're in. So
it's very subjective. Yeah.
I've always struggled with Wells on a sort of emotional and psychological level, because depending on how risk averse I'm feeling that day, I could give them that alternative diagnosis bit and give them the 3 points, push them up into the high risk, and then, or not. And on the Wells score, if we did want to use it, she got 1.5 for surgery in the last 4 weeks.
Mm-hmm.
Do you ever use any other risk scores for PE?
I mean, you can use the PERC.
You use PERC?
The pulmonary embolism rule-out criteria. To be honest,
I never got on with PERC.
No, it's one of those. It's a bit arbitrary, isn't it? It's like yes, no. I'm like, oh, it's just not quite enough information. It's not exactly. So I think I've probably developed my own little PERC score. Oh dear.
PERC of the job.
PERC of the job. I've got So my PERC of the right. Okay. So I think I've developed my own sort of clinical diagnostic probability pathway for PEs and DVTs because I've seen so many, and maybe it's something that's some with experience. But PERC I think is quite useful at the front door, maybe in ED, potentially in ambulatory care, or somebody who hasn't been seen at all by another clinician. But in this person, PERC's irrelevant. They've already been seen by a GP anyway, so you've already got that possible diagnosis there. So PERC's one. I mean, do you use anything else?
No, I just wanted to ask you about PERC. I don't know anyone who uses it actually. Maybe there are people out there screaming at their phones and their broadcasting devices saying it's fantastic, you should use it. I haven't been convinced. Also, the thing about PERC is you've got to score 0. If you get 1 point, you're out. You can't use it and you can't rule out PE. It doesn't diagnose PE, it means you can no longer say no, it isn't PE. And one of the points is age over 50. So there you go. So she's already got a point because she's 76. So it's a score for young people. It reminds me of the Ottawa score for subarachnoid.
I was just about to say the Ottawa score. Yeah.
You're over 45. Forget about. You've already got a point, and we have to think elsewhere. So if we were going to use PERC for her, she actually got 3 points: 1 for being over 50, 1 for recent surgery, and 1 for leg swelling. I don't think that's what kind of leg swelling they mean in PERC. They mean like idiopathic leg swelling, or or a DVT. They don't mean whoops, you've had your veins stripped and that's where your legs are swollen. So I didn't find Wells very helpful. I didn't find PERC very helpful. And it was my sort of lack of experience and confidence and my lack of a senior person around on that weekend day to bounce this off that made me take the road of being overcautious. And also I thought, well, look, if we did use Wells tells us if we gave her the 3 points for it, there's no other more explanatory condition, that gives her 4 points. Or if we give her a Wells score of 1.5 for her surgery and the Wells score of 1.5 plus a D-dimer that is more than 550 equals a 16.7% risk of VTE in this patient, according to Mr. Wells. I mean, and as I said, Wells shouldn't be applied to all and sundry. It should only be applied where there's a pre-test probability.
Absolutely.
So I was going down a road of a very broken reasoning, but I was grasping at straws. Short version, I did a CTPA. Okay. Do you want to hear the report?
I think so.
Okie dokie.
Yeah. I mean,
I
was just going to say something else, and I can't remember what it was. And it was about when you are working alone in that and the weekend, and you're seeing lots and lots of patients. Sometimes I go down the path of least resistance. And sometimes the path of resistance is not doing investigations and explaining to the patients and sending them home. That takes more time and is more challenging sometimes than saying, admit CTPA, because actually that is quicker and easier for us. It's not better for the patient, and it's certainly not better for the hospital as a whole to find a bed and all that. But actually, when you can't make multiple decisions because you've already seen 50 people, when you're exhausted, when the human factors of looking after each other, of working teamwork, it's not there. So I would have done CTPA.
It takes more energy, but it takes more sort of clinical calories that are burnt by saying to the patient, I don't know what this is, but I'm sure you will be fine. That's a very unsatisfactory thing for patients to hear. But sometimes it's the truth. And we shouldn't feel like we're compelled to go down the road of saying, I must make a clear diagnosis, coded diagnosis for this patient, otherwise I provided poor care, or I must finish this consultation by writing a prescription because, that's the dynamic, that's the model we do here. Here's a problem, here's a pill. We have to be able to take time to say, I don't know what's going on, or I know what this is, it's not serious, or I know what this is, and I don't want to give you a prescription for it because I don't think this will help you. I think that would actually be a step in the wrong direction. All of that burns energy, that takes energy from us. And it may be easier to say, okay, do you know what? I'll scan you from head to toe and see what we find. And of course, then we find incidentalomas and all sorts of things and all these Pandora's boxes that come up. And sometimes it's a case of, I'll admit you and do a bunch of tests because then someone else will get their hands on you and then apply their brain to the situation. And that's the only way to get a second opinion or a senior idea, senior support, is by admitting them and letting a day go over. And then the next day, a new team sees them and then see what they think. Not a great use of NHS resources or the patient's time, but sometimes I remember that being the only way I feel that I'd done right by the patient.
Yeah, absolutely. And it's certainly something that towards the end of the day, I probably do more of because I've already made so many decisions. I'm like, I can't make decisions anymore. I don't even know, do I want a latte or a cappuccino? Not that I make that decision often at work, but it is maybe more at home on a day off. But yeah, absolutely. Okay, so I think we've kept the listeners waiting long enough.
Okie dokie,
What did the CTPA show?
Of course it showed. There are extensive right-sided pulmonary emboli, including the distal right main pulmonary artery, the right lower lobe segment and subsegment. There are changes next to the right pleura suspicious for a developing pulmonary infarct. There is reflux into the hepatic artery, but no other signs of right-sided heart dilatation or pressure overload.
Wow.
I don't want to frighten people into CTPAing nothing. But you can see why this case has stuck around in my memory vault for the last 5 years, because she wasn't supposed to have that diagnosis. No. You know that old saying by Osler, listen to the patient, they're telling you. Yeah. Can we just admit that sometimes that's garbage?
No, because that's my favourite saying, and I say that every day.
And that's why I
agree with you.
I know it means a lot to you, but sometimes the patient knows no more than you do. And they because that patient was telling me, inverted commas, that everything was fine and she could go home. And sometimes if that maxim does not always work.
Maybe
but not 100%.
She knew about Osler and she was thinking, now what? I'm going to show that Osler man. No. Okay, yeah, no, I agree. And I also think sometimes we ask questions because we know what answer we want, depending on how busy we are and, how we're feeling emotionally, and are we tired, are we hungry? Absolutely. I mean, this case is making me think now, who have I seen today? And Mr. PE on. The challenging thing with this hindsight bias, I guess, where, in retrospect, do we then go on to, like you say, investigate every single person who comes in with the same presenting complaint, and what are the risks, benefits to those patients? And how do we adapt our working for situations like this?
Yeah, there are so many factors at play as well when we talk about what investigations we'd like to do. In that instance, I worked in an institution where getting a CTPA was relatively easy. But I have worked in other hospitals where the radiologists say, I don't think you'd give me enough justification to irradiate this patient. This, sometimes it's a young patient with, or pregnant patient or what have you. But any patient, they one of the roles of the radiology team is to not gatekeep, but to make sure there are sensible decisions are made about radiation exposure. And I do know, and I hope I'm not letting the cat out of the bag here or revealing any trade secrets, that sometimes stories are slightly altered or embellished or to get a scan that we want to have. And I think radiologists know this very well, and I'm sure it drives them absolutely crazy. And this is for good or for bad. And maybe we could do a whole session about this, about white lies in clinical medicine and why we do it and who we're doing it.
And it's that framing effect as well, isn't it? So, I'm selling a patient to you, to the radiologist, because I want them to buy a particular thing.
Yeah,
and also, if I'm buying something, I'm listening in particular to a particular thing they're selling because I want to buy a particular condition, and I know that's a bit of a roundabout way of trying to say it, but you know, you're absolutely right. We framing a patient, you know, it's all, you know, in the handover in the morning, and you're getting a handover from the doctors who've been on at the night, and they will sell a patient to you because they want you to diagnose them the particular thing to then refer to particular, you know, specialty. And that's, we do it, I think, all over medicine.
Yes.
But yeah, I think I love the idea of doing a white lies in medicine. I think that's definitely something that we should do.
Well-intentioned lies in medicine. Why we do them. That'd be an interesting paper, wouldn't it?
It would be.
Yeah.
Would we call it a lie or an untruth?
Well, already we're getting into sort of qualitative, you know, language, democratic discourse, aren't we, about the power of words? But I think
absolutely. Yeah, definitely. And I think, you know, the more experienced I get, when somebody discusses a case with me, they already know what diagnosis they want the patient to have and to give to me. And I'm not very good at not seeing the patient. I like to see all patients, and I know that's not, I think that's my control. I like to be in control probably a little bit too much, and I probably need to step away from that a little bit. But, you know, unless I've actually seen the patient myself, I find it very difficult to agree with a diagnosis.
I agree to an extent. I think we're recording this in the end of August. We've just had changeover for trainees, and I find this year I haven't met them. I don't know them yet. So they present a history to me, but I probably will still see the patient, because this sounds, and I hope it's not coming over like I don't know who to trust, but I haven't worked out where everybody stands in terms of their experience, and after a while, I'll get more of a sense of, I think this person, I've worked with them a few times, I've seen a lot of their patients, and I think this is probably a very, very comprehensive assessment, and I'm happy to go along with that. Whereas at the beginning of the academic year, I need to see for myself.
Yeah, absolutely.
Yeah. So it often depends who I'm working with.
Yeah. And it's about identifying your team's strengths and weaknesses, isn't it? And I know we've talked about neurophobia before. You know, you wouldn't want me to see a patient with a neurological problem. I am not the right person for that. Whereas a colleague of mine who is a rheumatologist and an acute physician who is excellent in neurology, you know, I'm like, go to him, he's amazing. Absolutely. So yeah, you're absolutely right. Okay, so what happened with this patient then?
Well, what would you have done at that point? She's sitting in my waiting room in ambulatory care, looking happy as Larry, with completely normal vital signs and that CTP report. What would you have done?
So I'm very reassured that she's still sitting in the waiting room looking well. Obviously, the CT scan reveals a different side as what's going on. So I would bring her through, try and find somewhere to sit or pop her in a bed if there was one available, and do another set of observations. Obviously, we know she's got a large infarct and emboli within the lungs, so she has a potential to deteriorate quite rapidly. And that would be my concern. So I would bring her through to a bed, do a set of observations, do another ECG, and then basically start to discuss exactly what we found on that CT and how we're going to manage it.
And I did a whole set of observations again. I also said, right, Janet, we're going for a walk. Fake name, not her name. And we went for a nice walk around the department with the SATS probe on to see she didn't saturate once. She didn't really get that breathless, really. It's almost a point where I was going, have I got the right report for the right patient? Because this patient,
well, you have to question that, don't you, actually? You know, that's not a bad point, actually. Is this report for the right patient? Because I've certainly been in situations before where they've been mixed up. So that's a good point.
I guess what I kind of started to get the sense of talking to her at this point, I got the kind of sense that she was a very stoical woman who didn't complain. And I started to wonder if, when she said, my pain's gone, my symptoms are gone, I feel fantastic, is that something she was presenting to me as part of her character, personality, and how much of it was real, you know? Yeah. And so I ambulated her. I did not admit at the hospital. Obviously, I started anticoagulation. I did the old PESI score. Do you PESI?
Yeah, love a bit of PESI. Pulmonary Embolism Severity Index score. Now, did you do the modified short one or the long PESI?
Listen, this was 2017. We didn't have no modified shortcuts in my day. So I used the long PESI. And it risk stratified her to, I think, low risk.
Okay.
And actually something I've learned subsequently is radiographic clot burden doesn't actually correlate with clinical risk. So a horrendous CTPA report isn't as dire clinically and in prognostically as you might think. So I explained everything to her. I said, look, you've had this operation on your legs. They pulled out some of your veins. I think what's happened is around that operation, you developed some little blood clots in your legs. But unfortunately, they've moved up north, got stuck in your lungs, and that's where they've caused this issue. And that probably caused that nasty bout of pain yesterday. Probably that was the moment she was infarcting pulmonary tissue. it's caused a little bit of a scar on your lung. But listen, we can treat all of this. What we need to do now is need to thin your blood down. So I gave him my usual counselling for anticoagulation, you know, things to watch out for, things to notice. And we still do an excellent anticoagulation outpatient clinic department here, and they follow everybody up. And I started it on a DOAC and sent her home for follow-up in a couple of days in ambulatory care, because I was reassured by her, my sort of gut end of bed assessment in relation to her, and probably would mean more clinically is a validated risk assessment tool, which was the PESI score. So those sort of things triangulating together made me think she's appropriate for ambulation. What would I do with her in a hospital bed except just look at her, you know?
Yes. Yeah.
She's not even tachycardic, so I couldn't even say put her on a cardiac monitor. So she would literally just sit in bed. And what happens when you put a 76-year-old in a hospital bed, a very independent fit, they deteriorate and they start to lose function. So, and this is, you know, the acute medic in me speaking, this is sort of the ethos and the heart of our specialty, is how do we avoid admission? You know, they should be the slogan of the Acute Medicine Society, avoiding admission since 2002. So,
and what's interesting about the admission, and I had a patient I saw on Monday who, I never want to admit anybody because I always think people are better at home in their own environment. And I always say to trainees, don't think about the reason as to why a patient needs to be admitted. Try and think about what reason is the patient giving you for them to stay in? Why can't they go home? And I had a patient who actually couldn't go home. She was an 88-year-old lady who just wasn't a possibility to send her home. And her daughter said to me, I really don't want her to stay in hospital because I know if she stays in hospital, she'll sit in bed and she won't do anything. And that's not a fault of her mom. It was just that institutionalization that we see in lots of patients. And I said, well, there are little things that you can do to stop that. I said, number one, get dressed in the morning. Act as though it's like a normal day. You know, you get up in the morning, you have your breakfast, you get dressed, you don't lie in bed all day sitting in the hospital gown or your pajamas. You know, get dressed, pop your clothes on and sit in the chair. And she went, oh, that's a good idea. Her mum wore makeup. I was like, great, pop some makeup on in the morning then. And it's little things like that if we do have to admit, how can we prevent that institutionalization, that lying in bed and muscles wasting? You know, is there anything we can do in acute medicine? Advise patients.
You're talking about I think there's actually a
pyjama paralysis.
Yes, pyjama paralysis.
It's
a movement, isn't it? A national movement.
And pyjama paralysis.
When you think about it, why on earth is it a law that when you're in hospital, A, you have to stay in your pajamas all day, and B, you have to lie in bed all day? It's crazy. It's crazy. Imagine if we had a ward where in the morning everyone got out of bed into the chair and the beds all flipped up on the ward like in a studio apartment. They were just put away for the day and you had to sit in a chair. I think A, people would be encouraged to get out sooner because they'd be sitting in a chair all day. And B, it would just help just the postural tone and just blood flow, circulation, ventilation of your lungs. I guess when I was a new doctor, the wards had day rooms and patients would put their dressing on and shuffle down to the day room and read a magazine.
Yes.
Whereas now you've got your TV in bed and there's no reason to get out of bed, I suppose.
Do you know, I've just had a blast from the past. The ward day room.
Do you remember when there were smoking rooms as well?
I do. Where have the day rooms gone? You know, I remember when my first job back as an F1 and F2, we had day rooms in all the wards. Yeah. And the patients would walk down to the day room, sit and chat and watch telly together. And they would be up and down.
Yeah, otherwise you didn't watch TV. And they'd argue over the remote and who got to watch,
they would.
versus Country File and all that sort of stuff.
That is, I mean, I know where they've gone. They've been taken up with bed spaces and offices and...
Yeah.
But yeah, maybe we should bring back the day room.
Yeah, absolutely. Because otherwise there's no reason to get out of bed. And we need sort of, nudge theory. We need to make, just rather than tell people what to do, we need to make little nudges that make getting out of bed worthwhile. If everything is served to you and present you in bed, then why get out? When you think about it, it's crazy that we do this. I've seen on Twitter someone said, imagine if there was a consent form for being admitted to hospital. Have you seen it?
No, no, I haven't.
Yeah, they said, imagine if we had to get this kind of consent form, and he said, procedure, admission to hospital, indications for procedure, observation. This is, I suppose, more for the older population. Risks of procedure, loss of independence, loss of continence, loss of muscle tone, weakening, functional, and had listed a whole bunch of stuff. Increased risk of mortality at 6 months, increased risk of mortality at 12 months, increased risk of falls, increased risk of delirium, and all this sort of stuff. And you go, wow, hospitals are pointless places to be. And yes, so that does drive a lot of my decision making about admitting people to hospital. I wouldn't.
And I think it's important to explain to the patient and the relatives and the staff why we're sending them home, because I often get some kickback from a variety of people, because I do like to send patients home. Obviously, if they're acutely when they're really sick, I'm not going to send them home. But some people come, oh, I just want a couple of days in hospital.
Yeah.
Trust me, you don't.
I don't feel well enough. I don't feel well enough. I don't know about you. I never say you're well enough to go home. I always say, so you're in recovery now. You're going to get better. You're now well enough to continue your recovery at home, because that sort of stops the conversation. I can't go home. I'm not well yet. We don't stay until you're well, till you're normal. It might take you a couple of weeks till you feel your normal self again, but you're well enough to continue your recovery at home now. You're safe to do that. But you're right, there's pushbacks. A lot of it is cultural. But I am ill. You said pneumonia. I know that's a hospital reason, and it's difficult to push back sometimes, especially to multiple people if it's a family.
It is, and we have a lot of discussions in acute medicine with other consultants within the department, and I'll say to them, why are you keeping them in hospital? And they'll be like, well, you send everybody home, and I'm like, no, that's not the question. What is it about this patient? What are you doing for them? So if it's just for observation and they're well, I actually don't think the best place for that individual is in a hospital bed on a very noisy ward where you can't sleep, that you have to share a toilet with 6 other people. And I just think, is that really the best place for somebody to recover? Sometimes I do think I'm singing my own little tune.
I'm with you
Because I think it is a culture change, isn't it?
It is, yeah. And trying to find ways to nudge people into not being bedridden when they're in hospital as well. I think it is a big
it is. Yeah.
Great.
Great.
A clinical question.
You can.
About this lady, right? Would you have thrombolyzed her?
No.
Why not?
So I've thrombolyzed a few PEs in my career, not many. I'm a bit thrombolysis averse, to be honest. Same with strokes as well. So thrombolysis really should be for massive pulmonary embolism. She's hemodynamically stable at the moment. She's got a normal respiratory rate, normal blood pressure. She's not tachycardic. She's very fit and well. For me, to thrombolyze a PE, it's when somebody is becoming unwell, they're becoming hypertensive, tachycardic. At the moment, there's no suggestion that I would need to thrombolyze this patient.
Yeah, if you look at the PESI score, it's sort of if you're PESI class 4 or 5 or something, but you can get into that score, that high risk strata, and still be well-ish, because you get your age, for example. I know they've recently changed PEs. It used to be massive, submassive, but now it's high risk, medium risk, low risk. And PESI feeds into that a little bit. But you can, if you're sort of 90 and frail and your heart rate's 101, you can find yourself in the high PESI score where it says query thrombolysis, discuss with consultant. Whenever I get phone calls in the dead of night when I'm on call for medicine, it's nearly always the med reg saying, oh, hi, I've got a patient. I don't know whether to thrombolize or not. And I'm with you. I pretty much say, what's the blood pressure? 120 don't thrombolize. I'll see them in the morning. Because it is the hemodynamic instability. But of course, there are now more details they ask for, like what's their TROP, what's their BNP.
Yes, exactly.
If they're marginally raised, these patients can find themselves sticking up a big red flag saying consider thrombolysis. But for me, it's not something I've done it maybe once in 17 years. So I normally would just say, look at the blood pressure and their hemodynamics. Unless that's gone wrong, we can sort this all out, I think, with a bit of oral anticoagulation, maybe monitoring as an inpatient for a while.
Yes, I think that would be a better situation rather than thrombolizing and all the risks that come with thrombolysis. It is, let's keep her in hospital then and observe. And that seems a much more sensible option. Absolutely.
And do you echo these patients routinely?
I guess if they've any signs or symptoms of right-sided heart strain. I know if there is a large clot burden, there is some who do suggest that you should do an echocardiogram, maybe a little bit further on down the line to look for signs of pulmonary hypertension. What I would love to do is, and I'm not trained in echocardiogram, focused echocardiogram. That's certainly something that I need to do. You said that you have done echocardiogram in the past.
I am,
yeah. And would you echo her at the front door to look for that right-sided change?
I don't, but I've noticed that people do now, and I'm wondering if I'm a dinosaur, or whether we over echo. I've noticed that people tend to get an echo as part of a PE workup to look for right heart strain. I spoke to a colleague of mine who's interested in this sort of thing, and he says, I don't, because if you echo people who've had a PE, they're going to have right heart strain. It's a given, and it means nothing. It doesn't change anything. It's how the right heart responds to high pressure. And he says it's much more valuable to do an echo, as you say, 6 months later to look for sustained pulmonary hypertension in terms of prognostication. I guess the only, maybe if they had a very high troponin.
I guess if they were in acute failure, maybe, but I mean, I suppose if they're in acute failure and you were thinking of another diagnosis as well, would they, just because they've got a PE doesn't mean there's not something else going on. But it's not something that I routinely request in patients who've had a PE, to be honest.
Okay, interesting to know. So we're quite similar then. I mean, I'm very, very open to anyone who's more clever than me.
Yes, absolutely.
Tweet me at Dr. Ben Lovell or whatever, get in contact and point me towards any evidence saying I should or shouldn't be doing this, because it's something I do want to be informed about. But I ask around and people tend to give the same consensus as me. I just noticed there's been a creep of routine echoes coming in at the front door now. It's just because they get a PE.
Yes, I know. And then the problem is, I mean, I get loads of echo reports that I then have to look at, and I'm like, what do I do with this? Yeah, interesting. Really interesting case. I think it's raised a lot of questions in, patients who are referred have already been seen by one clinician. Do we re-question that diagnosis, or do we go along with that diagnostic momentum? It's very difficult to question somebody else's diagnosis, isn't it?
Yeah.
Yeah. What are your learning points from that?
I guess I would say, I mean, even though we've talked about their shortcomings with this case, there are tools out there to either guide your thinking or justify your decision making. If you've already decided you're going to take a course of action, it's always nice then to back it up with a validated metric or a risk stratifier. And we've talked today about PERC, we've talked about PESI, talked about Wells score. So sometimes these are useful ways just to add weight to your decision making, or sometimes to guide you through the darkness if you're not sure which direction to go. I guess my other thing is, it's not really even relevant to this case, but I love the discussion we had about admission and admission avoidance. And if people just wanted to think a little bit about how we can avoid admission, considering all the risks that are associated with it, how can we use ambulatory and community-based services if available to you better? And how can we prevent the inevitable deterioration or minimize it for inpatients just by trying things such as getting them dressed and sitting out in the morning, or sitting out for their meals, or making that part of your plan on the ward round. Like, today plan is we're going to give you these intravenous medications and you are going to sit in that chair for 1 hour during the day. And here's why I need you to do that, and just giving them some rationale for it. Yeah, so I think
that's some really important points. I mean, I've been known, I get patients up out of bed sometimes, put them in the chair, I'll go for a walk with them. Because I'm like, come on, get out of bed, we can go, let's go and have a wander. Basically, because I want to get off the ward myself. Yeah, exactly. And also, I often think sometimes when I am on the short stay wards or we do acute frailty, and I actually want to see how they do mobilise myself. So I'll be like, come on, let's get you out of bed and we'll go for a little walk. And I'm like, actually, they're pretty good on their feet. Let's get you in your chair. Let's get you walking to the toilet. Absolutely. Brilliant. Thank you so much. Again, some really, really interesting and very pertinent points raised there.
Thank you. That was a really good chat. I enjoyed that. Thank you very much.
It was, me too. I think what we need to do in future episodes, we're going to do one on white lies in medicine. What do we tell ourselves and each other in medicine? And also, I'm going to start a campaign to bring back the day room.
You're going to find that space, are you? Okay.
I'm going to find that space. Yeah, I know. I haven't even got an office. I mean, a day room is a stretch.
Right.
Yeah. I work anywhere. That's why I go to the toilet now to do some work. Okay, thank you so much for that conversation. Again, it was really enlightening. I mean, anybody has any questions, any queries, please feel free to tweet at either of us on Twitter. We're both on there, and any questions we would love to answer. Thank you to everyone for continuing to listen and to make the Home of Medicine podcast one of the top medical podcasts in the country. Thank you, everybody, for listening. Goodbye.
Bye-bye. Thanks. Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.